Okay, so we're gonna have this kind of format today. We're gonna have a panel of, starting in no particular order, Eugene Park, because he's right next to me in Philadelphia, Wee Lam in Singapore, and Paula Pino in Chile, in Santiago. These are all very talented, very smart people who know quite a bit about cerebral palsy, and I've learned from each of them. So hopefully we'll have a lively and controversial discussion. And maybe, hopefully, we won't agree on everything, right? So the panel has not been informed of the cases that I'm going to present and really the content. They've just shown up cold. So I'll moderate and then just encourage open dialogue between the participants, and also if you want to put any chats. And Andres, I'll put you in charge of scouring the chat for any questions, if that's okay. And
yes,
then,
great, for sure.
Yeah, and then I thought we would start by getting everyone on the same page. So there's a lot of terms that go around, and I figured that we would spend some time defining what these terms mean so that we can move forward talking the same language, even though we're all in different countries. Okay. And in terms of cases, I thought we would start in the shoulder and move down, and I have some combination of real cases and theoretical cases just to make sure we highlight sort of the details of how we treat this problem. Okay, that's our panel. And let's start with some terms. Okay. Do we have a definition for cerebral palsy? I believe we do. But just so that we're clear on what we're talking about when we're talking about spasticity and all of these kinds of things. I'll pick on Eugene.
All right. Cerebral palsy. So I think a lot of these terms are similar but different. One could fall under the umbrella of the other, but cerebral palsy is a upper motor neuron injury either during the time of gestation, or I believe the technical time frame is any kind of upper motor neuron injury that also occurs in the first 2 years of life, is what the American Academy of Neurology calls it. So yeah, a brain injury during the first 2 years of life or intrauterine.
Yeah, so you'll have patients come in and they'll say that they don't use the term cerebral palsy very often. They'll use something like intrauterine stroke or an ischemic brain injury or an upper motor neuron injury. And in some ways, depending on the parameters, we're talking about the same thing. Do you have any comments, Wee?
My favorite definition is the one by Beck's, 1964, a disorder of movement and posture, and then he updated it in 2005 to include, very rightly so, all the other senses, including sensation, cognition, communication, etc., to make it a truly multidisciplinary disorder to be managed by a multidisciplinary team.
Yeah, it's very interesting that you say that. So I think one of the things that we often overlook is the sensory component. And that's a really big problem. As we know from patients who have other neurologic injuries or even amputations that lead to a prosthesis, sensation is really the key to use of the limb. If you don't know that the limb is there, it doesn't feel like it's yours. And so I think if you have a truncated sense of sensation in your hand, you're just not going to use it to the same degree, and it's not going to be as useful to you because you're going to have what Scott calls visual efferent. So you're going to need to be staring at your arm when you're doing it, or in your legs. Again, you don't have the same kind of proprioception even. which is also not something we talk about. And so when you think about how difficult it is to coordinate, and when you think that each muscle has about 50% of its axons, maybe even 60% are sensory, and you lose that as well, that's a big problem. Paula, any comments?
Well, I think I agree that stereognosis, proprioception, it's key to measure. I don't know if if the panel has an agreement on what they use to measure it, because that's one of the main challenges. Even it's already difficult to measure in a standardized way what we want the patients to do when we're examining them, and getting to the sensation and stereognosis and proprioception is even more challenging, I think.
Yeah. In terms of if a patient comes to you and says they had an intrauterine stroke, does that make it versus ischemic brain injury? Does that make a difference to you in how you manage these kids or what you think about in any particular way? Or does the cause change the effect, so to speak, for you? I think you're muted.
So yes, so I don't have a big series of just tabulation of all the patients, but I think that the patterns may change, especially with ischemic brain injuries, or patients that will be a little bit older when they have their injury, and probably the way that they contract, there's contractures is a little bit different. As I said, I don't have a pattern just to tell you this ones will be worse, but I think that they don't act the same when they had meningitis when they were really young, when they had a stroke, intrauterine stroke.
Any thoughts?
Yeah, this is something my neurologist taught me, which I thought is really useful. So I do make it a point to find out what the cause of the we use cerebral palsy as a very broad term, but I do try to make it a point to find out what the cause was. And the majority of causes are, I think from what he's told me, is that they are antenatal, periventricular leukomalacia. So premature birth is a big factor. Often there's not a lot you can do about it. But the important thing about antenatal causes through periventricular leukomalacia is that the child is usually born with diplegia or paraplegia presentation, and that's really important. So we're no longer looking for the hemiplegia, spasticity alone presentation. These children are usually quite disabled, and then even the ones that has the prolonged labor, and they are usually quadriplegic as well. So you're really looking at a very small subset of patients with maybe a stroke after birth, who presents with that hemiplegic pattern that we are quite used to dealing with as surgeons. And so I think the cause is really helpful to if we associate it with the presentation.
Yeah, I think what's interesting is what you're saying, if I'm interpreting, is that any kind of global insult results in a global injury, and any kind of targeted insult, such as a stroke, will end up with a more specific, more targeted deficit, right? Which sort of makes sense.
Yeah.
So I think, yeah, I don't know if it really makes any difference for me other than establishing the pattern, which is, I think, really important, right? So you don't miss things. But I think those things become somewhat evident in your exam, right?
Yeah, I guess to a certain extent, I will be thinking more about the intellectual ability of the child,
Sure.
whether he or she can cooperate with rehabilitation. I'll be thinking about the lower limb So I think it does help me in terms of seeing the child more as a globally rather than just the upper limb and what I can do for the upper limb, for example.
Yeah, absolutely. Eugene, any thoughts?
Yeah, I definitely agree with all of those things. I think the etiology of open motor neuron injury definitely does matter in terms of their motor presentation. Um, for example, children who have periventricular leukomalacia, like we said, will present a certain way. Lately, we've seen a string of kids who've had Zika virus and microcephaly
Mm.
present with certain types of spasticity and dystonia. And they definitely present with an identifiable pattern, with a lot more shoulder proximal limb-based spasticity and dystonia, um, compared to the kids who have this perinatal ischemic injury. So depending on what causes your motor disorder, I think they do present a bit differently.
Yeah, well, it's a good thing you mentioned some more terms. Look at that. So now we can, Gene, since you mentioned spasticity and dystonia, can you give us a sense of what these things are and how do we differentiate these sort of four terms
Yeah,
that
so
we
there's a little bit of controversy in how people use these terms, right? And I think
right?
people
That's
use
yeah.
them a little bit interchangeably in some senses, but the simplest way that I've started to think about the top two, at least, spasticity and dystonia, is spasticity is a externally triggered muscle response that causes rigidity during movement. And you could think about this as a two-way street. It's a uninhibited cycle where a afferent input from your spindle fibers causes a uncontrolled firing of your efferent motors. Dystonia, I think about more of as a one-way street. This is a involuntary triggering of postures or motions that is not triggered necessarily by external stimulus. So, you'll have patients who hold certain postures or patterns of movements. Um, and yes, sometimes it is triggered by like their stimulation status, but it's not necessarily induced by external movement. So that's how I differentiate spasticity and dystonia, just in terms of description. Athetoid, I think, is a pretty specific form of motion disorder, which kind of falls under that dystonic umbrella of repetitive and writhing movements. And contracture is probably the most different in that you're talking about muscle tendon units now and that have permanently shortened.
Yeah. So I love Paulo Selber has this great definition. He says spasticity you can feel and dystonia you can see, which I think goes to your point of passive versus active. All right. So I think what I wanted to highlight, well, I'll ask do you have any other comments on the terms? Do you agree with the definitions?
I think contracture is a different thing, isn't it, Dan? Contracture
Yeah,
is
for
sort of
sure.
the end point of spasticity. Spasticity being one dominant pattern, flexion, extension, whatever, being left unchecked, that led to nobody really knows what the problem is. Most people say it's fibrosis of the muscle, but I think it's much more than that. I think it's the extracellular matrix. But something happened, and therefore the whole muscular tendinous unit, the fascia, everything shortens, and this leads to contracture. But my simple surgeon brain would usually differentiate spasticity and dystonia, including athetoid, into lesions affecting the pyramidal and the extrapyramidal tract. And I find it actually quite fun to try and work out the brain lesion without first reading the notes in the clinic. I will see, as you say, dystonia. You see the movements, and then I will try and guess where the lesion in the brain is. Probably works better for adult strokes. So I can sometimes quite easily predict a basal ganglia stroke, for example. in a patient presenting with dystonia, it doesn't always work that way, because I think if you have a massive stroke, you will affect the pyramidal and extrapyramidal system. But it's quite useful. Again, there's lots of clinical implications, because you can explain to the patient that probably surgery is going to help, surgery is not going to help. And also it helps me understand what medications they are on, because you are using different medications for pyramidal and extrapyramidal systems.
Yeah, these are excellent points. I think we've all learned that the athetoid is its own kind of its own kind of trouble. And your point is correct, I think, which is that contracture is sort of the final, it's an endpoint of having your limb stuck in a certain position for a long period of time. But the mechanism of that is probably more complicated than just having your arm just positioned that way for a long period of time. Some of it may have to do with growth, right? The muscle may not grow to the same degree if it's not being stretched. Paula, are you still there? I don't know if you have any comments on these things.
No, I think I agree with what has been said, that, well, spasticity will be very different how you see it, and the patient will have a very different attitude when as dystonia or athetoid movements. And there it's very important to be able to examine the patient more than once before, if you're planning surgery specifically, or being able to use toxin to assess the patients, specifically with dystonia, because sometimes you see the patient for the first time and you think that's their posture, and then you see them another time and the posture changes. So you have to be very careful with those patients when you're planning surgery.
Yeah,
and I think
yeah, go ahead, Paul. Sorry.
No, and I was just saying that contracture is different, is completely different, and it's probably the end point of being very spastic. So those patients will develop just postures that you cannot just take out with toxin or by stretching.
Yeah, I don't know if I understand why some patients are they look the same, and then you get them to the operating room or you use a toxin and suddenly you realize they don't have a contracture at all. Right? How does that happen if they are contracted all of their time? So let me move on to some. I think we've sort of hit that. We're going to consider, I think, this is just kind of a schematic of all the kinds of things that lead to deformity, loss of function, contracture, and things we do about them. But let's go on to some cases. We'll start with the shoulder. This is a boy named Dominic, 17-year-old with spastic quad. The shoulder rests in 90 degrees of external rotation and 45 degrees of abduction bilaterally. So he kind of sits like this, right? Difficulty for him, obviously, is getting through doors and being in his chair. So he has purposeful movements in his elbows and hands, although he's fairly dystonic, but he doesn't have any athetoid movements. And the way I think about dystonia is it's just a lack of coordination, as you were alluding to, from the location of the neurologic injury. And so it's sort of, he can't quite get to where he necessarily wants to go, and he can't coordinate his movements, but he does have purposeful movement. He has passive internal rotation to his belly, so you can take his arm and bring it all the way in. And he has active internal rotation only to neutral, so he can get his arms kind of here, but then they rest like this, and then he gets them to here. He has passive adduction, abduction, 0 to 135. So passive motion is actually quite good. It takes a little while to get there, but you get there. But active adduction, abduction is only 45 to 90. Again, dystonia, but no athlete. Do we need to do anything here? Is this like a real problem? The fact that he can't get through doors, and that he's bumping up against things and injuring his hand? Should we do something? Any thoughts on what you might consider, or what any more information you would like?
What's his intellect like?
Oh, it's pretty good.
Okay.
He speaks English and what's the other one?
No, it's
Anyway,
fine. It's fine. That's all. That's what I wanted to know. So this is somebody he does he use his upper limbs for
he
any
does.
function?
He
He
does.
does.
Yeah. He can feed himself, although not very well.
So the main problem is that he's sort of bring his arms out and he's getting stuck.
Yeah, and whenever he gets excited, he does like the
I
touchdown.
know. Yeah, it's a really difficult problem then, as you know.
Yeah, that's why I'm bringing it up.
Have you tried toxin to his deltoids, supraspinatus, and seeing what that does?
Yeah, so toxin to his external rotators and toxin to his deltoid really improves his overall function. And he can bring his arms further in, and he actually likes it quite a bit because his arms don't sit up all that much anymore. Yeah, but it goes away. So 4 months later, he's back.
So you're looking at some form of hyperselective neurectomy to some of these branches around the shoulder muscles.
Okay.
Is that where you're? Yeah.
That's right. Yeah. Approach. How would you approach it in terms of surgical approach? How would you, well, let me ask this, Paula, would you consider anything else other than hyperselective neurectomy? His abduction doesn't bother him as much as his external rotation. Could you consider a rotational osteotomy?
I mean, probably you can, but I don't think that it will solve the problem really well, because he'll still do the reflex like opening, even though it's a little bit more internally rotated. So I think that trying the hyperselect, I would do the hyperselective first as my primary option. And if it didn't work, you always have the human rotation osteotomy to go afterwards.
Yeah. Eugene?
Yeah, I think about this problem a lot actually. Um, so in children, this generally tends to be the children who are a bit more devastated, and in more circumstances, they tend to be intellectually impaired as well. But sounds like this child is pretty smart. So the way I think about it is, I do try to treat it in a nerve-based manner. So hyperselective neurectomy will treat primarily the spasticity, the dystonic signals, the efferent dystonic signals will still be there. So in the cases where I have done selective neurectomy for the posterior deltoid, infraspinatus, and teres minor, what I see is that the frequency of their external rotation dystonia definitely decreases. But like Paula was saying, when they're stimulated, when they're not paying attention, all of a sudden, they will jerk. And then I will have those patients then work with therapy to try to strengthen their internal rotators. When I ask the parents, like, oh, do you think it made a big difference? They're like, yeah, I think so. I think the frequency of this happening is a little bit decreased, but I definitely still see it happen. The kind of surefire way to make sure it doesn't is really just to do a neurotomy of those muscles. Now, do you do a neurotomy of the posterior axillary? Do you completely cut your, branch to infraspinatus? It's a little scary thought in someone who has pretty good cognitive function, but I think overall it probably does help their function to not get stuck in doorways and to not all of a sudden jerk into this external rotation. For these kids, for the amount of ability that they have, I don't think there's a whole lot they're going to do volitionally in this posture. If they're able to keep their shoulders in and still able to reach hand to mouth, I think that's probably a more functional posture. But I do get a lot of pushback when I suggest that to parents, so I do more often end up doing a selective neurectomy, and it does decrease the frequency a little bit.
Are you, if you're going to do a neurectomy, are you afraid of throwing off the balance in the other direction, where they're now having problems with hygiene in their axilla, where they're having trouble washing themselves? And does their mental status really, their cognitive ability, make a difference in how you think about these
I
things?
think you're hitting the key point there. Their cognitive status, right? Like, are they washing themselves? Are they completely dependent on their parent or caregiver? You could address the internal rotators and the adductors as well, right? Through selective neurectomy. So if they're dependent on a caretaker, you could treat the external rotation dystonia just with a neurotomy. And then now if they're tight with spasticity of the internal rotators and adductors, you can always approach your pec major, your latissimus, teres major. That generally is just through a selective neurectomy to ensure that they have at least some adductor tone left.
Yeah. Anything to add?
There's so many variables here, Dan. I mean, this is not spasticity. This is spastic dystonia. So
Yes.
everything you do, you are just sitting there thinking, is it going to go the other way? This is like the opposite of an obstetric brachial plexus palsy, isn't it?
Yeah.
This
Yeah.
and you're thinking, okay, what about doing some tendon transfer? Well, and I mean that's why the first question I asked was he how is he intellectually? And I guess the second question I should ask is he's 17. How long has he been in this posture for? So we really should be thinking that he should be really should have this predominant pattern for at least a few years. For me not to worry that if I do something nerve related, he's gonna bounce the other way and end up with
Mhm.
an internal contracture. So I
Yeah,
guess
that's
those are
what
the
I'm worried about
two key questions. Yeah.
yeah, that's what I'm worried about with neurectomy. I'm worried
The
that he's
other
going to go the other way.
The other thing that's I'm sure you know about this, that's sort of slowly appearing on the horizon is the cut and repair. So cut the whole nerve and repair it because the afferent seems to regenerate and the patient regains strength, but the efferent regenerates in a haphazard manner. So the feedback is reduced and maybe the spasticity will reduce. I don't think there's enough evidence out there, but I think that's probably going to be quite a popular method in the future that many will think about.
Yeah.
That's actually a good point. I want to ask you. I know that you've treated dystonia a lot in the forearm with selective neurectomy, and I'm sure you've tried the cut repair method. Have you
No, I
found that
haven't.
it affects
I haven't.
dystonia?
I haven't tried the cut and repair tech.
Oh, okay,
I
okay.
do I do hyperselective neurectomy. I make sure I use Botox several times. I use lidocaine several times. I make sure the pattern is predominant for a few years. And even then I still been caught out. I still did the hyperselective neurectomy and it still went the other way. Then it comes down to patient counseling. So I don't know. Maybe cut and repair will be the answer.
It's
Maybe
interesting to think about how cut and
yeah.
repair will affect dystonia. With
Yeah.
spasticity, I've heard, people like Dan and others say that you get a lot of recurrence, but I wonder how it affects dystonia.
Well,
I think
so
it's all sorry, go.
no. I was just going to address the cut and repair. So Sami Tufaha has done quite a bit of work on animal models, looking at hyperselective neurectomies versus cut and repair. And what's really interesting is that it's unclear whether hyperselective neurectomy works in the manner that we think it works. Because what turns out is that when you cut the afferents, what you're getting is you actually do get sprouting and you do get reconstitution of the afferent innervation to the spindle fibers. He's shown that in a rat model, even though they have improvement in their spasticity. But, and cut repair does about the same thing. What it does is it changes the morphology of the spindle fibers, which is really interesting. They don't return, they sort of permanently damage. What I found in terms of the cut repair is that age really makes a difference, as it does for hyperselective neurectomy. I think the younger they are, the more robust the system is, and you have a much harder time disrupting it, meaning they can recover pretty easily from any insult you place before them. Yeah, the cut repair may be helpful, and Sammy and I have been talking quite a bit about trying to make the cut and repair worse, meaning make it so that there's a mandatory gap that the limb has, that the nerves have to overcome. Anything short of a critical gap of 1.5 or maybe even 0.5 centimeters. But so yeah, so I don't know the answer to this. I think this is all an evolution. But to your point, Gene, I'm not so sure that, yeah, the dystonia will always be there, right? You can mute it by just decreasing the spasticity and decreasing the sort of overdrive of that muscle. But I think you're right. I think it's always going to do this to some degree. But still to try to get the arms back in. So just to tell you what, we did end up doing neurectomies, and that did help with the abduction, and it did help with the external rotation posture, but he still got out here. And so we ended up doing bilateral humeral rotational osteotomies in addition. And that finally helped. And now he sits there,
Yeah.
he can bring his hands to midline. So the point is, and I say this to my patients, and I don't know, I'd love your thoughts on this. I say to them that it's like playing golf, even though I don't golf. You have your drive and you do something, you try to get near the hole, and then you're just putting after that. Right? And you may have to do things. Sometimes you go into the woods, right? And you have to get back out.
There's actually a couple of really interesting comments in the chat about what we were talking about. So Mohammed
Yes, you're failing me.
Salam talked about selective dorsal rhizotomy at the cervical level, which I know Bertelli's described before, but kind of accomplishes similar things to selective neurectomy, I think. But and Andres talked about the type of wheelchair, whether that could help this patient, and how do you take that into consideration? I have one child with a very similar presentation right now, where I did a selective neurectomy of the shoulder external rotators. And like I said, the frequency of the external rotation did decrease. But what we did also was that we changed the material of his armrest on the wheelchair to something that's a bit more grippy. And actually, that's made a lot of difference in his overall posture. So those little things actually could help quite a bit.
That's really interesting. Yeah. Gene, do you have any thoughts on how you approach surgically the shoulder in terms of denervation of the internal rotators versus denervation of the external rotators? Do you do an axillary approach? Do you do a deltopec? How do you get there?
So for the external rotators, I'll either have the patient lateral or prone, and you have to get into the quadrangular space. I find that access is made a lot easier if you detach some of the posterior deltoid, and that allows you access to the spinal glenoid fossa, so that you could have the inferior extent of your suprascapular nerve. We have a nice video on this that hopefully we'll be able to upload at some point. But yeah, posterior approach. For the internal rotators, I've tried a couple of different approaches. The first approach, which I learned from the Paris group, is trying to keep everything axillary, and that way you do have access to your ansa pectoralis. You do have access to your branches, to your latissimus and teres major. I have found that it's difficult to get very distal on your pec branches through that approach. If you really want to get a selective neurectomy, I actually do a infraclavicular approach to the pectoralis, split the heads of the pectoralis to find the branches that go to the pectoralis there. And then the latissimus and teres you can approach axillary with a little extension down the posterior axillary line.
Yeah, that's very helpful. Paula, or any comments on that, or anything you do differently? Okay, all right. So let's move on. So same case, but passive motion is terrible. Does that change your algorithm?
I think you start if you don't have good internal rotation, I think you probably will prefer to go to do the humeral rotation osteotomy first. Probably do it both. So I think in that scenario, trying to get him in, it will be less functional probably if he already has limited passive motion, because he cannot do it in any time. So probably he'll be even more happy if you do a humeral rotation osteotomy at the beginning. And trying to do a hyperselective to just prevent those just jerks as much as you can. The other thing that it's important, I think, is that if you have a way out of what you're doing, like just if it goes the other way, and if you have a surgery that will solve just the antagonist that you would be unexpectedly seeing, that would make me more, I would be more at ease of doing that surgery. Just having a way out of just getting stuck internally.
Yeah, so what you're saying is don't do plan A unless you have a plan B. Yeah. Would you consider doing muscle releases, and how would you go about that, or not?
So you're saying, are we talking about the same patient, Dan? Because it's getting more
Like
complicated now.
imagine same patient, except passive motion's terrible. You can't adduct them. They're stuck out here, and they're stuck in here. You can't get them past neutral.
So you gave Botox and nothing happened.
Yeah, you Botox them and they still are here and they're still there. Yeah.
So I mean, I'm really talking hypothetically now. I think you're probably looking at a mixed picture of contracture and spasticity and dystonia.
Yeah.
So
yes. And I
so
think
you're
just for the people in the cheap seats, I'll say that what you're saying is actually really important. I don't know if everyone picked up on the nuance of what you just said, but you're talking about looking at each of these things independently, the contracture, the spasticity, and the dystonia, but also how they affect the big picture. And so I think pulling those things apart and seeing how they influence each other, but dealing with them as somewhat separate entities, I think is really important, because they lead you to different treatment strategies.
or a combination. So I think that probably you'd be looking at, I mean, you've done the humeral osteotomy. That should change the posture, but you might, I guess you might be, I guess that's not bad, but if it doesn't move enough, I think you got to think about some form of fractional lengthening or some form of contracture release. And if you worry about recurrence, then you combine that with hyperselective neurectomy. So that's a lot of surgery, and whether you do it in stages or you do one thing first, it doesn't work. So I guess in your first surgery, which I picked up, you did the nerve surgery first, and then you did humeral osteotomy second. I think in the first surgery, you probably did the nerve surgery together with some form of release of the contracture. And I was just trying to pick up again what you said earlier. You thought there was no contracture. You thought there was contracture, but when the kid was put under general anesthesia, then the whole picture changed, and you have no idea what you're dealing with. Is that what? Is that what you're?
Yeah, so you go to the OR and you think, oh, it's all this great passive motion, but you don't have passive motion. So yes, this was not the case. I'm just throwing this as a theoretical. But I think that when you lose passive motion, when you do have a contracture, it sort of changes your algorithm. And now the problem is it's very difficult to do fractional lengthening of the external rotators.
Yeah.
Right.
The tendon is so short.
It's very difficult to do fractional lengthening of the deltoid. Gene, do you have any pearls on how to do that?
No, I've never tried that actually.
Yeah, so I mean, the only thing you have for the external rotators is to do a slide. That's really it. I'm not so sure I would detach the deltoid as a plan operation. I think I might go with a humeral osteotomy more so, but I don't know if you guys have tried anything else. All right, so let's leave the shoulder because we have much to talk about. And all right, let's talk about the elbow. Right, we're moving on down. So let's just say same patient. Elbow rests in 90 degrees of elbow flexion. Passive motion is 10 to 145. Active motion 45 to 100. And then you get this moderate resistance to flexion, right? What we have now defined as spasticity, and severe resistance to extension. So their biceps brachialis, whatever it is that's flexing the elbow, very spastic, but he can overcome it to about 45 degrees, but doesn't get much further than that. If you hold it, you can get him to 10. And they're both symmetrical. So again, dystonia, but no athetoid movements. So he's kind of does like this, right? And then he kind of does that. But his extension is clearly much harder to get to. His elbow flexion is much better. All right, Eugene, we'll start with you.
So again, there's some mixed motor disorder here, saying that he has some dystonia at baseline. So you have to, just get a good understanding of their motion disorder. And like Paula was saying before, you always want to see them multiple times. You want to record them on video, and then, go through testing the different muscle blocks. But I think overall picture, the way that I approach these kinds of situations with pretty much intact passive motion is that you want to do a nerve-based approach. For someone who has spasticity of both elbow flexors and extensors, even though one is more impairing than the other, I've generally found that you want to treat both. Because when you treat just the flexors, they'll come back with more impairment from their extensors and vice versa. And I think probably, some of the people who have described this procedure, I think, are here. But selective neurectomy through a medial arm approach for the musculocutaneous, small anterolateral approach for your radial nerve to address the brachioradialis. And then I just make a longitudinal incision on the posterior aspect of the arm, and I'll do a little lengthening of the triceps to treat the long and lateral heads. And that gives you access to the medial head of triceps underneath, where you could actually find the terminal motor branch there and do a selective neurectomy of the triceps there. If there's a lot of triceps spasticity, I'll also find some of those very proximal, the common branch of your long and lateral heads up here in the medial arm, and try to do a bit more of a proximal selective neurectomy there as well.
Yeah, Paula, any thoughts? Would you consider doing a release of the elbow or just nerve work for the 10-degree flexion contracture?
I think I would just leave the 10 degrees of elbow flexion contracture. I think that the results of a selective neurectomy, if you're addressing the 3 elbow flexors, if you're going radial and to the musculocutaneous nerve, is more than enough. And the patients are really happy with the results they get. So I think that just lengthening their elbow flexors, you're probably going to interfere more with their strength. And just that 10 degrees, it's okay to just leave it. Even I will be happy leaving from 30 degrees downwards of elbow flexion contractor, especially if they're in a wheelchair. I think that they're okay with their elbow flexion. And the other thing about what Jean was saying is that the triceps hyperselective neurectomy, even though this patient has some spasticity of his triceps, I think I would stage it just because they're at the beginning they're a little bit weaker. So I think that it's just good to see what they get out of it. And some of the patients that I've done, even though I find that they have triceps spasticity in the beginning, when I first examine them, then they don't have a problem with it, and they don't ask for it most of the time. So I haven't had a patient still that just gets stuck in extension, even though I'm afraid before doing the procedure that they have triceps spasticity.
Yeah, so and to follow the golf analogy, you're gonna use a smaller club.
Yeah, and besides this, because probably, and in my practice, most of the times these patients, I know that we're focusing on the elbow, but most of these patients also have wrist flexion deformity. So most of the patients want more things done than just the elbow. So in my way of viewing it, I prefer doing probably the flexors, just going to the elbow and going to the wrist because they're really bothered by the wrists. And then if they need something else, probably doing more fine work in the hand and probably doing the triceps. That's the way I would do it.
We as a tiebreaker,
I think I would probably lean towards Paula rather than Eugene in staging it. But I'm just again I'm trying to just consider this elbow in isolation. I'm trying to forget about his shoulder and the fact he can't get through the door. And I think we're looking at a few things here. So my first thought looking at your 5 points, severe resistance to extension, and my first thought is that there is a contracture. But then he's got passive motion 10 to 145.
Yeah.
So he's got severe spasticity.
Yeah.
But then, and I'm thinking, but he's got triceps spasticity as well, moderate and severe. And then he's got dystonia as well. So, I'm thinking, am I going to do anything for this child? I mean, what are we trying to do here? Are we trying to help him? I mean, what are we trying to achieve here? Because there's quite a lot of things that could go wrong here.
Yeah. Okay. I love what you're saying. So I think this is the critical Peter Carter 2-4 rule, which Scott Cozen talks about all the time, right? You can do things to somebody, but are you really doing it for them, right? So the question is, what do you gain, right? And I think the house scale is really valuable for me in how I think about it. And I think that for me, the way that I think about these kids, or really I've started thinking about all kids, is there's sort of thresholds that you have to overcome, to improve function. You get them better, but they're not better enough that they change their function. What have you done, right? This child has difficulty reaching out and getting to his, being able to move his chair, right? So he has to really struggle because of the spasticity in his biceps getting out, and he would love to get his elbows straighter. His mom tells me that it's really difficult to put a jacket on him and to get him dressed. So that's part of the reason why they want something done for the elbow. The elbow, it's more the elbow flexion that's a problem for them. Elbow extension's not as much of a problem for them because he can't quite get there, right? He rests in about 90 degrees. So yeah, I think Paula's point is well taken, right? There's no harm in coming back and doing something else later, right? But I think Jean's point is well taken too, which is why if you're pretty sure that you're going to have to come back, you might as well do it all at once, right? And try to limit the number of surgeries for these kids because they tend to visit the operating room a lot. But I think you have to ask the question, what are we doing this for?
I
Right?
think one of the points you just made, these kids visit the operating room a lot, is pretty important. And also, Dr. Leclerc had a pretty good comment in the chat you can decide whether you're going to treat the triceps or not by doing toxin injection for your elbow flexor first. And that's a nice logical way to do it. I think my approach has kind of been molded just over time. And the fact that when you do a selective neurectomy, like what are you really losing? Just when you treat both at the same time, you're there already. And so, why not treat it is kind of my thought.
Yeah, what's the downside?
The downside is that the child has dystonia, and that's the downside.
That does muddy the picture a bit, yeah.
Yeah.
Yeah. That is the downside. So Carolyn's on here. I think, for her, it's pretty amazing that here we are discussing all of these things, and we treat hyperselective neurectomy as a, yeah, of course, right? So that's a kudos to her for really pushing that, and to we also for introducing me to it. So amazing how far we've come, I think, in the treatment of spasticity, that we're having these discussions in a way that 10 years ago we wouldn't have, right? 10 years ago, we'd be having a completely different discussion. Even 5 years ago, completely different discussion. And I think LeClaire is a very large part of that. So kudos to her, and thank you for pushing the ball down the field a little bit. All right, so let's talk about more. And now that she's on, I welcome her to make any comments that she would like. So, wrist and hand. Okay, let's move on from the elbow. And then, well, let me ask one more question about the elbow. Let's say you were doing a treatment for the forearm, or let's say there was actually a contracture. Would you do a contracture release and hyperselective neurectomy at the same time? Or again, would you favor the cautious, slow approach of one at a time? I'll start with Paula.
I would do both. Probably, especially I think at this point I would do both, and even voluntary patients that have voluntary control of their extremity and patients that don't have voluntary control. Of course, if they don't have voluntary control, it's even easier the decision, I think, because if they're a little bit weaker, it won't affect them as much. But I think that at this point, I've seen enough patients that we do both, and if they have elbow flexion contracture more than probably 30 degrees, I would go ahead and do the tendon lengthenings and then do the hyperselective neurectomy, so they don't have spasticity and recurrence afterwards.
Yeah, Eugene?
Yeah, I very rarely address muscle tendon without addressing nerve as well. I think we have this tool to be able to address some of the underlying spasticity. So basically always doing selective neurectomy to address that in addition to treatment of contracture.
Yeah, it's an interesting point. I think for me, it's the same. I think about the neurectomy is sort of the baseline, and then whether I do a contracture release depends on whether they have a contracture or not. But it's almost always sort of a given for me, unless they don't have any spasticity and they just have a contracture, which is pretty rare but does happen. Your thoughts on that?
So Dan, I mean, it's a very broad question. Would you do both at this? And I will answer that with a very broad answer that yes, you should do hyperselective neurectomy to reduce the chance of recurrence. However,
yes.
So if I want to sort of pick on specifics, I think if I do a tendon or a muscle procedure, I think it's more of a tendon procedure, and I think there's no chance of recurrence, then I wonder whether I should do a hyperselective neurectomy. For example, if I do a superficiality profundus transfer, I mean, why would I consider a hyperselective neurectomy of the FDS? For example, if I lengthen the FCR and I do a Z lengthening and I suture that, pretty lax, am I worried about recurrence of the FCR? But if I do a fractional lengthening of the FCU, definitely I will combine that with a hyperselective nephrectomy. You know, so on and so forth.
Yeah,
So if I do a fractional lengthening of the FDS, then yes, I'll be very worried about recurrence.
yeah.
So that's speaking on specifics.
So it's really, so that's, yes. So I think for me, I don't do STPs anymore. Like, right, if you're going to do a fusion, you're not worried about the risk going back into flexion necessarily, right? If you're going to do a tenotomy, you're not worried about it. And if you're going to do a really loosening procedure, then yeah. But I don't do STP transfers, and I do almost always, well, not always. I would say I favor doing a flexor pronator slide over doing anything else, because I think the functional outcome of that compared to an STP is a huge difference. But I have seen recurrence after a flexor pronator slide. So I think you're right. If you're looking at it, the more tendon you do, right, even though it's going to come back, you still are never going to reach the threshold of recurrence probably. But if you're going to do something more in the functional range, right, then the neurectomies become more at play, right?
You know, one thing that I think we should add to this list of techniques, I also employ flexor pronator slide. I know there's a lot of controversy whether that's a functional or non-functional procedure, and hopefully I could show some results in the future, just kind of showing that you do get function back. But like we was saying earlier, a lot of these problems, our understanding of contracture is evolving to see that a lot of the extracellular matrix contributes a lot. I've seen Eva Ponton present pretty convincingly before that in addressing the extracellular matrix with some fascial releases, that you could get a lot of relief of these spastic contractures. And the nice thing about that is that you are not losing that muscle tendon proportion. You're not losing that unit length. So that's one thing that I might add to this list of ECM releases. I haven't done it because I haven't really learned the technique, but I would love to really learn more about that.
Well, I think she's here. I don't know if she makes a comment. Maybe even in.
Can you
Yeah.
hear me?
Yes.
Yeah. So now I'm going. I take away, like Zancaldi showed in back in the days, I take away all the aponeurosis and then go through down to aponeurosis between the muscles. It's quite a lot dissection, and then I cut the small intertendinous intramuscular tendons, and with that I get out the hand like this, and then I cast it, and then what is kept is the selective motor control. So the ones I've done that on, they have a weak grip, but they have a very good control of the different fingers, and it's balanced. And so I think we need to look into what really happens after a couple of years in these different techniques. Perhaps we could do an MRI or something of the muscles and see how it differentiates after a couple of years. With the selective motor neurectomy, what happens in the muscle after a couple of years.
Yeah, I mean, these are the big questions. Caroline has now what, 2-year data, something like that.
I think she has 5-year data coming out soon,
5-year
right?
data coming out soon. Yeah, exactly. So it's all very exciting, and I think we've all been watching our patients change over time. Some for better, but a lot for worse, which is kind of interesting. So let's see. Here's a case. Finally getting to some videos. for you, we look at this hand, right? You see the wrist extension, right? And she can open her fingers and she can close. This is obviously not a child, but she's been living with this for a long time. Any thoughts on what's going on? And she's hemiplegic. The other side, you can see her mirror movements. I'm trying to get that.
I feel that with these patients, their hyperextension of their wrists worsens their intrinsic spasticity, and it's really difficult for them, even though if they have finger extension, to extend the MCP joints. So bringing that wrist down helps a lot in that intrinsic spasticity. And probably with this patient, you don't see if she has any wrist flexion control, but probably doing a procedure that maybe we don't know anything else. I'm not sure how much she uses her hand, but probably doing a fusion of that wrist may help, and afterwards addressing the spasticity of her intrinsic muscles.
It's an interesting point. So somebody who has active finger flexion and extension, I should have put this on a loop. Considering something like a wrist fusion to bring the wrist down, right? Neurectomy of the extensors, lengthening of the extensors, anything you would do, anything more diagnostic that you would want? Eugene, any thoughts on that?
I mean, it certainly does look like there's hyperextension. I think we would need to see a lot more video to see whether she has some volitional motion there. She looks like she has some intrinsic spasticity as well. But she's got really good selective motor control, which I think is in her favor. Yeah, I think I might try maybe toxin for the wrist extensor first and see how that helps to relieve things. If that's the case, you could come back and try to do selective neurectomy. If not, then certainly wrist fusion could help to bring that wrist down. You could also kind of see her elbow is struggling there with some tone. But yeah, I think I would start with toxin and maybe a block first.
Yeah. So, anything else?
I've got to examine her then. I can't really comment without examining her. I mean, she can't extend her finger. She might be trying to compensate with her wrist. I don't know. I mean, I need to
Yes.
see whether I can
So ask me,
passively.
I'm the exam. You can ask me questions.
Can
Yeah.
you passively get her wrist down to neutral? Is it
No,
all tone? Is it contracture?
you can get her to about 30 degrees of extension, and that's about it.
So there's some contracture there
Yeah.
in her finger extensors, maybe wrist extensors.
Yes.
And
her MP extension does improve when you bring her wrist down a little bit. But she still has that swanning, and she still has that the clicking, the snapping intrinsics, or the snapping lateral bands.
And her as Eugene pointed out, I mean her brachioradialis looks very, very high tone biceps as well. So that whole it's a global upper limb problem, isn't it? It's tone in the bicep, in the elbow.
Yes, she has not much of an elbow flexion contraction, maybe 10 degrees, 15 degrees, something like that, but she postures in a lot of elbow flexion. You can see her biceps is very spastic, as is her brachialis. And you can see the brachioradialis is really firing, as are her wrist extensors, all the time. Thumb looks like it's in a reasonable position, right? We're pretty happy about that. And has a lot of volitional finger flexion and extension, but she's clearly, the wrist extension is a problem for her, and intrinsic spasticity is a problem for her. So let me I did an ulnar nerve block. There you go. And close. Well, that does it better. And then give me and you can see that her extension has actually improved, and her hand function is improved. Interestingly, she still retains some thenar function. How's that feel? Is that So this is something that I do a fair amount of, is when I think there's intrinsic spasticity, I just block the ulnar nerve and see how aggressive can I get, right? If I block the ulnar nerve and their function really improves, then I'm pretty happy. I've had some patients that I blocked the ulnar nerve and they do much worse. Their hand function sucks. So I think that's a really nice temporary way of doing an neurectomy. And then you feel like you can be much more aggressive if you know that an ulnar nerve block has really helped. Yeah, Eugene?
Yeah, this is I think what Dr. Leclerc has been kind of talking about lately with the PULM, the ulnar motor neurectomy.
Mm-hmm.
And so, as you know, I don't treat adults. This kind of picture's very different than what you see in kids. But you know, you have improved function with the ulnar nerve block. You probably have some degree of contracture that's going to serve as a check rein to clawing. So I think in this case, I might consider just doing a motor ulnar neurotomy.
Yeah, yeah. I haven't treated this patient yet. I think she's on the list. She may be a cut repair with a very nice gap. 'Cause
Are you worried about if you cut the motor branch completely, you will take out
her thumb
her
function.
key pinch? Yeah, it's quite
Yeah,
important, isn't it?
yeah. So I have done.
It's a function of hand.
Yeah, so I have done. If you look at her thumb, actually, her thumb function is quite good. I have done a Palmer approach and cut all of the and done neurectomy of all of the intrinsics, or sorry, all of the interossei. And that's been incredibly helpful. I have some Parkinson's patients that have a lot of intrinsic spasticity. But interestingly, it's really interossei and their thumb function remains, which is very weird. I don't know why. And so I have done that. That's a very good point, Yep.
And I think Caroline's has put a good point as well. I think you did it on our nerve block, and she can flex the finger better, but there's still some degree of interossei contracture, isn't it? She can't.
For sure.
Would you say? Yeah, yeah.
Yeah, for sure. I'm not sure that I would say that to some degree that's a beneficial thing because it's going to keep you from clawing if you have some MP contracture.
Okay.
Yeah,
I'm just wondering whether doing a release of her intrinsics might be sufficient rather than doing a nerve-based procedure. I'm just, you know.
Yeah. Well, that's the question, right? And you can be more targeted if you're releasing individual muscles rather than doing a complete neurectomy, right? And to your point, I think separating out the thumb intrinsics from the finger intrinsics, if one is functional and one is not, or even being more selective about which fingers. You know, we have a lot of patients that have swanning, particularly of these two, but not of the small and ring for some reason. I don't know why that happens. There's certain patterns to this. There's sort of the dystonia index finger, if you know what I mean. Like for some reason, their index finger does this weird dystonic thing, but their other fingers do not. Yeah, so I think this is the difficulty. And I don't think we have an answer for this unless anybody has a discrete, tremendous amount of experience doing denervations of the interossei versus doing releases.
But I think we made a pretty good point that you know you don't always the new is not always better. You know, if you're able to address the individual interosseous nerves, that's great. I think that's a bit more difficult. But she seems to have pretty good thumb function. She's reliant on her adductor. So I think Wee's right that I would probably choose to approach this maybe with a proximal intrinsic release for index or small.
Yeah, I think part of what was swaying me was the fact that with the block, she has quite a bit. There you go. But it may be that, you know, she may have a connection from her median because she's still really functional at the thumb even after the block.
Give me a pinch.
But maybe I didn't do a full block,
How's that feel?
right?
What would you do for the wrist, Dan?
Yeah,
Would you?
I don't like fusions in general.
Mhm.
I might try something short of a fusion, like a denervation of the extensors, and probably do a lengthening of the extensors, do a fractional lengthening, and see if the risk comes down. I've done that with, when you do well, actually, I don't do too many FCU transfers for wrist extension, but I've seen a lot of them from others that come in with hyperextension of the wrist, and I'll fractionally lengthen and denervate the FCU, and that actually works really well to get them in a better position. So I think I would try the same thing first, and then use a fusion as my fallback, my plan B, as Paula would say. I don't know if does that seem reasonable?
Yeah, I think bringing the wrist down will really help with the finger opening. If you lengthen just the wrist extensors, bring the wrist down, it will help her with the finger opening. Then you can address whatever intrinsic spasticity is there in a staged fashion.
Yeah, although I probably do everything at the same time, do all the nerve work at the same time.
Have been great in this video that you filmed after the ulnar nerve block. Have the wrist down and just see how contracted those intrinsic muscles are.
Yeah. Well, you'll know as soon as she's asleep. All right. So we have about 15 minutes. And we'll do Wee's not going to let me speed round because he's too nuanced. So I wanted to show sort of 3 different hands. So all of these hands have severe flexion posture of the wrist and hand. They all look like this, right? When you look at them, they're all sitting there like this, but they're all different, which is really interesting. And I'll show you. So one patient has a Volkmann's of 45 degrees of extension. So it goes like this, right? And they're active Volkmann's, which means what's the level of their wrist that they can fully extend their fingers, right? It doesn't exist. There's no active wrist or finger extension. They just sit like this, right? You can stretch them out, but then as soon as you let them go, they go right back, right? Another patient has a Volkmann's also 45 degrees of extension, right? But the active Volkmann's is good to 15 degrees of flexion. So they can open their fingers with their wrist in 15 degrees of flexion fully, and no active wrist extension. You can hold it there, right? And then third patient, Volkmann's is now 30 degrees of flexion, and active Volkmann's in full finger and full wrist flexion, meaning they can't move their fingers at all. No active wrist or finger extension. So you're talking about patient 1, to go with Wee's sort of paradigm, has no contracture, right? But very spastic. And then you can't even assess dystonia in their hand because there's really no motion. And then patient 2 has good active finger extension, but lacks wrist extension and has no contractures. And patient 3 has contractures, and you really can't assess their amount of spasticity or anything else because they're so contracted, right? So I just want to show you, this is patient number 1, and this is 6 months post-op. This is after I did a selective neurectomy of the FDS and FDPs. And I think I did, let me see the list.
Hand, okay, like that.
Hold on
Yeah,
1 second.
and then close your hand.
And if you look,
Can you do them both together?
he doesn't really have much
No, I mean both hands
finger
together.
flexion
Open up.
other than intrinsic finger flexion, right?
Your right hand too.
If I'm going to be
Both together.
critical.
Yeah.
This is about 6 months out.
Both hands, okay, and then close them as much as you can.
It's like shocking the improvement.
Okay.
And I denervated his FCR, and
And
I
if you turn
denervated his
palm-
FCU, and I denervated all of the finger flexors. I
Turn your
denervated his
left palm.
pronator.
Turn your palm down. Get you.
Yeah. But you can see that his finger recovery has been not so great, right? But he loves it. He's just so happy. And I'm wondering, to Paul's point, like maybe more aggressive neurectomies. And I will tell you that now he's about 2 years out and he's had some recurrence. So now his fingers are more bent. So I think that perhaps being more aggressive, given that he's functionally really good without having really much of any IP flexion, right? It's all of his intrinsics,
Hands, okay.
but
like
he's so
that,
much more
yep.
functional.
And then close your hand. Uh-huh.
Then there was no pre-op contracture at all.
No?
Nothing.
Okay.
When I got him to the
Nothing.
OR, when I got him
Ready
to the
to-
OR,
yeah.
he was
Both
like this.
together. Yeah.
My plan was to do a flexor
Okay.
pronator slide
Both
because I thought he
hands,
was really
okay.
tight,
And then close
right?
it as much as you can.
And then nothing.
Looks great.
And do you know if he had any finger flexion control before you did the hyperselect?
You couldn't tell because he was so flexed. Like if you opened him up, he would maybe give you a little bit of something, but not much.
This is a patient that was preoperatively probably sounds like it's non-functional. And what you've done is that you've done a nerve-based procedure to get the fingers out. And it's a lot easier to clean, and he can put his hand on his lap, and
Yeah.
yeah,
Exactly.
I think, yeah.
And then one patient told me that she's a 65-year-old stroke. I did a cut repair of all of her finger flexors, and she's also had some recurrence, which is interesting at 65, but she's still much better. She had no function in her hand at all. She can now open. Yeah, I think this is all still an evolution. This is the other, these are both cerebral palsy patients. They're both hemiplegics, and they're both sort of in their 20s. This is patient number 2. This is him 6 months post-op. I did denervate his elbow, and I did lengthening of his elbow flexors since he had a contracture. And I did an ECU to ECRB tendon transfer for his wrist, and then denervated his wrist flexors. And that's it, because he had fairly good functional hand, to Paula's point, with the wrist held in about this position. So here he is.
And I want you to bend your elbow, touch your nose. Okay, straighten it. And then bend it again. Okay, straighten it. And then can you do this, palm up? Okay, and then palm down. And then go like this. Bring your wrist up as high as it'll go. And then make a fist. Open. Make a fist.
So,
And open. And make another fist.
and you can see there's some intrinsic
Bring your wrist up and down
spasticity
like
still,
this.
right?
It's great.
But he has the ECU to ECRB. Well, we can talk about that, but we don't have much time left. Versus
Sorry,
FCU.
Dan, we have 2 questions in the chat box.
Yeah, let's do it.
One from Caroline Leclerc. If you can comment on the FDP FDS operative approach for case 1.
Yeah. So the denervation. Yeah, the approach to the denervation. So, yeah, you can find with a longitudinal approach in the sort of middle of the forearm, you can find the branches, and I usually will follow them out. I find the nerve. Usually when I'm doing that, I'm denervating also the wrist flexors. So I'll start at the elbow. I'll identify all the branches of the median nerve, and you can find the FDS and branches, and you can find the branches from the AIN as well to the profundus, and I just follow them out under the pronator. And usually I'm denervating the pronator, and I'll do a little bit of a fractional lengthening so that I can get a little bit more of an exposure. You don't really have to take it down because you can work on either side of it. And then I'll just follow the nerves out until they dead end into the muscle. And then I'll do the denervation there. It's actually easier to do it when you're doing a flexor pronator slide because you're looking from underneath. But I will tell you that I have missed branches that I didn't see. And I've had sort of like this, where everything got better except for one.
How long is your incision? Can you comment on just how distal you have to go?
Yeah, about mid-forearm, distally. Yeah.
And when you do that, so you're using probably the tech point or just nerve stimulator to just identify.
I am using a nerve stimulator for sure, because that's how you, that tells you, I mean, you can, the problem is there's so much variability in that area. It's very difficult Sometimes the FDS branch will come off with the FCR. Sometimes it goes into comes off after the AIN. It's all over the place in terms of variability.
But what I've said that each branch, when you're going just very distal and almost into the muscle, each branch stimulates, especially in the FDS, FDP, stimulate different fingers. How do you choose which one to take out? Because sometimes it's one stimulates index and middle, one, if you're in the FDP, will stimulate only ring finger. How do you choose?
Yeah, so you'll see sometimes branches will stimulate multiple fingers. Is that what you're getting at? Right. Yeah. And then I just follow more distally. So I'm gonna be a little bit of a heretic here. I actually think that you can very comfortably cut the whole nerve as long as you're in the muscle. Now that's going to be controversial, but my biggest problem to this point has been recurrence, not too much. And so I've gone to being really aggressive with the denervation of the fingers. And in general, I think based on Sammy's work, you are basically putting a terminal motor nerve inside a denervated muscle. You're going to get some renervation. It's a neurotization, whether you like it or not. So I think that's the source of a lot of our recurrence. And I think to Sammy's point, the hyperselective neurectomies may not work the way we think they work. It may not be the lack of afferent renervation, but it may be how severe an injury you cause to the spindle fibers that makes a difference. And I think that all these things will eventually renervate. Yeah. All right, Wee's shaking his head. All right, hit me.
No, I didn't. I wasn't shaking my head.
Oh, okay. All right.
I think that's quite wise. I mean, I'm just thinking that in the patient one, is a non-functional hand, and I think you achieve your objective of probably completely denervating the finger flexors. I don't know. I think it's very difficult to gauge. I think it's very difficult to do hyperselective neurectomy in a functional hand where you're trying to preserve exactly the function that you want to preserve for the FDS and FDP.
Yeah, I completely agree. Yeah. It is a bigger risk in a functional hand. And I think that if the child or if the adult, whatever it is, has a has function, but can't utilize it, then I think it's worth that gamble. But yeah, I think it's always a little scary.
And I want you to bend your elbow.
See, hold on.
Touch your nose. And I want you
to. There we go. Here's the other child. This child had a contracture, and I think this will be our swan song here. This child I ended up doing a lot on. This is a child who had no active finger extension, and was spastic, had contractures. So this is like the full court press. Everything's been fractionally length. No, he had a flexor pronator slide. Then after that, with denervation of the flexors, and then I ended up doing tendon transfers for the thumb. And I did what's interesting, I did him awake. And I transferred his FCR, which was functional, which I didn't know ahead of time, really. And I transferred that to his EDCs. I had a suspicion that it was functional, but I didn't know for certain. And once I had him asleep, I could see, or once I had him blocked, I could see his FCR firing, and I transferred to EDCs. Yeah.
Let's take a conference.
Oh, yeah. Hold on. Oh, okay. So here's the grand picture is a bunch of denervations of his wrist flexors. He then regained wrist extension, but he had no finger extension. So I did an FCR for wrist for finger extension, and I think it was a palmaris to EPL, perhaps. I actually can't remember. But here's what he looks like.
All right.
And this was,
Your
again,
fingers.
a very non-functional hand.
Close. Bring
And
the
it's
wrist up,
pretty amazing
and then close your fingers.
when you
Bring
do
your
have a
wrist.
tendon that you can transfer, that is functional. That gives you so many more tools.
He's really-
And then you can see I ended up doing central slip tenotomies for him. You can see that on his fingers.
Can you bring your wrist up and hold your fingers up?
And his central slip tenotomies sucked for a while. And I way overdid it.
Close again.
And I ended up having to put him in extension splints for about 6 weeks until his fingers could extend again. So I don't know if you guys have any tips on central slip tenotomies or alternatives for swan neck deformities. A lot of quiet. Yeah.
We have
So
some comments in the chat from Dr. Soldado. For spasticity in hand region, dorsal rhizotomy is highly effective and reliable. HSN is not because anatomical reasons. Any comments?
I'm not sure you can make a blank statement like that, but a blanket statement like that. But I would say that I don't have experience with rhizotomy. I know he does, and I think that that's certainly something that we should be exploring. I'm a little bit concerned about the level or the degree of rhizotomy that he does from 5, 6, 7, 8, and leaving only T1 intact. I think that's a lot of afferent loss for a limb that probably is deficient anyways. But I don't know how this will play out. So I don't know if you have any comments, Eugene, Paula.
I just don't have experience with dorsal rhizotomy in the cervical region, so I'm not sure.
Yeah.
I'm not really sure that dorsal rhizotomy is more anatomical than HSM. I mean, I'm just looking at those two comments like that.
Yeah, I'm not seeing the comment directly. I'm only relying on what Andres said, but I think anatomic, this is pretty anatomic. I'm not sure. I mean, it may be more efficacious, but I'm not sure it's more anatomic. But that's irrelevant. If it works, I don't care why. Right? Yeah. Chesco, do you want to make do you want to speak? All right. So, I think the other thing I will say, let me see.
Open your
There we
fingers.
go. There's all the stuff we did. This is another flexor pronator slide just to show the effects. This flexor pronator slide with denervation of the wrist. I did not denervate his fingers. And just to give you an idea of, this is several months out, maybe 6 months out. And you can see he's retained his finger function. People talk about flexor pronator slide as losing finger function. I don't think I've ever lost finger function from a flexor pronator slide as yet, but perhaps I haven't done enough.
It's more intrinsic also in this one. I don't see a lot of IP flexion, PAP flexion.
Mm-hmm. Yeah, he didn't have much before, and that's about what he has now. But you can see he does have some.
There's definitely some IP flexion, and I think I have lost function in some patients with flexor pronator slide. I think you have to be very careful in how you splint the patients afterward. You don't want to, slide the muscle a devastating amount where you're not going to have any muscle excursion afterward. So you just have to be very moderate in terms of how you immobilize them afterward, I think.
Mm-hmm. Yeah. When we started, we used to do this, like the waiter position. And I think that may be too much. And then I used to leave them for 4 weeks. I leave them now for 2. And then I bring them back and I put them in a removable splint. And I found that their function does yeah, they do get better. I worry about recurrence. To Wee's earlier point, right? You go too far, you don't get recurrence, but then you lose function, right? Or you remove the chance of function. So I just want to finish with the thumb since we're over time, and
Open.
just show a thumb.
This was like 2001. I don't
From the side, open.
And you can see this sort of mildish thumb and palm deformity, but clearly a problem. And you can see his ECU to ECRB tendon transfer there.
Open, 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 open.
Here I'm doing a Bouvier maneuver. Pretty good.
Can you give me a thumbs up?
So that's thumbs up right there. Clearly a problem. And I think the thumb is a perennial problem in these kids and in adults. Eugene, hit me on your latest and greatest on what you're doing for thumbs that are contracted, spastic. Are you doing denervations? Are you doing releases, combinations, osteotomies, fusions?
I kind of approach with a combination. Yes, this is a milder presentation, like a house one thumb, and I'm sure you could passively correct this, but I have found that if you just do a selective neurectomy of the deep ulnar branch, sometimes you don't, I don't know if it's I'm just not aggressive enough, but sometimes you don't get as much relief of the postural deformity. So I will generally tend to do a thenar crease approach and still release the adductors. And after releasing the adductors, address the deep ulnar motor branch to the adductor as well with a selective neurectomy. I think the adductor release has been viewed a little negatively in the past, but it is very effective. You just have to be very thorough with your release. I think it's not just your third and second metacarpals, but proximally you got to release it off of the capitate. That helps to relieve some of that CMC flexion posture deformity that you get a lot with these house one and above thumb and palm deformities. And I have tried, in addition to that, trying to pin the CMC and extension afterward, which I think does help. And I got that idea from you, Dan.
Well done. Any thoughts on this? I know you can't examine the patient, but I will tell you that the patient has limited extension, even passively. So about what you see is what you get in terms of passive. And the first web space is very tight. There's very little skin there as well.
I'll keep it very short, Dan, because of time. I agree with everything Eugene has said. I think the problem here is not just the how do I put it? The problem here is that there's not enough active extension. There's not enough extensor motor. And I agree that the thumb is one of the most difficult digit to try and restore normality. So I've tried brachyradialis transfer to whatever I can find there, and whatever I do, I just don't seem to get good extension. So I tend to sort of accept if I can get a thumb out of the palm and reasonable movement. I just never seem to get a normal thumb with everything I do.
Yeah, I think part of the problem is tendon donors, right?
Yeah.
As you're saying. Yeah, I've had some where the brachyradialis is fantastic and they get really good extension. I've had some where the palmaris is really useful and they get good extension. But if you don't have volitional control of any motor of a tendon, you're clearly not going to get good thumb. But I think Gene's point of being more aggressive, that I think has changed for me. And that was an interplay between Gene and me over the last year or so, as we've been pushing each other to be more and more aggressive, I think, on the thumb. And I'll just show you what we ended up doing. That's the approach. And I've seen that a lot of these long-term contracted thumbs, they lack skin in the first web space. And since I have a background in arthrogryposis, I've gone to the stiletto flap to fill in the gap. And I find that this has been really, really helpful. I'm doing this in about 50% of patients that I do a thumb release on now. It's actually, you don't really need it for the approach. I think you can do everything from the thenar crease, but I think it gives you a nice expansion of the web space that you can see there. There it is, healed. And you can see that as long as you keep it full thickness, you can get the tip to survive, which is really nice. This is a contribution of Pete Carter and Mary Beth Isaki and Scott Oishi, which I think is a really amazing flap that has lots of utility. So perhaps that is, Andres, any comments that we should address in the chat?
Yes, another comment from Dr. Leclerc that says HSN frequent need to include median innervated muscles and include recurrent branch HSN.
Yes. I think that's a really good point. What I find is the abductor pollicis brevis is probably a beneficial muscle in the thenars because it pulls you out, but the opponents and the flexor brevis clearly are not helpful. And those I think are really important to both lengthen and denervate. And I think that's part of what we've been pushing each other to do in Philly for more thumb opening. And that's been really, really useful. So yeah, thank you for that comment.
And the other comment was previously by Chesco that says that everyone should read Bertelli's papers about anatomy and technical steps.
For
He did have the
rhizotomy.
one. He did have the one paper on doing selective dorsal rhizotomy. I think he may be the only one to have written about cervical selective dorsal rhizotomy. So, and he does describe pretty good results with it. It's worth reading, but I haven't seen other descriptions of it. Only that one.
Yes. So perhaps it's a future PULM talk, Jesco. Maybe we'll talk about rhizotomies over some mate. All right. So thank you. Hopefully this was, I think this was really helpful to me. I learned a lot today. And thank you for all the experts that were around and commenting, even though we didn't put you on the panel. But I didn't want to tax these people too much since I feel like they're always being asked to do these kinds of talks. So thank you guys, and really appreciate it, and look forward to next month.
Thank you, and good seeing everyone.
Thank you.
Thanks,
Bye,
Dan. That was very helpful. Thank you.
Thank you.